Hello, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Today we present highlights from a recent webinar regarding cardiac imaging and specifically cardiac MRI in cardio-oncology. Today's presenter is Dr. Olga Toro-Salazar. Dr. Toro-Salazar is a professor of pediatrics at the University of Connecticut Health Center and director of non-invasive imaging at Connecticut Children's Hospital. When you enjoyed today's highlights, I'm sure you'll want to check out the complete webinar, which you can do at the ICOS website. While at the ICOS website, you can find information on all things cardio-oncology, including information regarding the upcoming Global Cardio-Oncology Summit this fall 2025 in South Africa. So please enjoy today's highlights.
So when to perform or consider a cardiac magnetic resonance imaging, first, if there is poor acoustic windows by echocardiography, if there is a change in systolic performance, and so if there's a change in systolic function with drop in ejection fraction more than 10 points to NEF, less than 55 in pediatrics, or GLS drop more than 15% or less than minus 17%. If the patient has baseline myocardial dysfunction, which is a significant risk factor for cardiotoxicity, if there is a previous history of congenital and or acquired cardiac disease, suspicion for myocarditis or pericarditis or new valve dysfunction, any tumor that has a significant hemodynamic effect, and we see that frequently in our patients with Hodgkin's lymphoma, and also to consider in patients who may have moderate or high risk of developing cardiotoxicity. So why the use of cardiac magnetic resonance imaging? So we know that CMRI is the standard of care in the evaluation of left ventricular volumes, mass, and function. And it's really important, as you'll see that in our case presentations that we'll do later today, that you really need to look at both the volumes, and MRI can give you a really precise estimate of that, as well as ejection fraction, a myocardial deformation, as well as tissue characterization of the left and right ventricular myocardium. And as I mentioned before, newer 4D flow sequences that enhance our understanding of flow dynamics in the evaluation of heart failure. So CMRI offers a superior reproducibility with lower inter and intra-observer variability when compared to echocardiogram. And there have been multiple studies, but I'm highlighting these here, where 2D echo had significant variations in measurements of ejection fraction. And unfortunately, the variations that we see by echo could be higher than the thresholds that we use to identify cardiotoxicity. So it is really important to understand that. And in addition to that, at the 50% LV ejection fraction, at least in this study, there were approximately 10% of participants who were misclassified. Our experience is that echo typically overestimates ejection fraction. So when we see declines in ejection fraction more than 10 points, or we might confirm findings by cardiac magnetic resonance imaging to really have a baseline understanding of that will lead the management of the patients. So for assessment of ventricular mass, volumes, and global function, we obtain a 3 and a 4 chamber view, as well as short axis stacks for measurement of volumetrics. And what we see, and this is a part of our early cardiotoxicity study, is that there is invariably a change in percent change in ejection fraction in almost every patient. And you can see that the thresholds may vary from very low to significant thresholds. So it really depends on what is the threshold that you're considering to really call these cardiotoxicities. And the characteristics typically are, as I mentioned, progressive decline in ejection fraction with a progressive increase in end-systolic volume index. And the interesting thing is that the changes in end-systolic volume index really mimic the changes that you see both by global longitudinal strain and global circumferential strain, and you can appreciate that here. And the changes in global longitudinal strain always precede the changes in global circumferential strain. And we'll see a lot of examples that give you that information. Very importantly, we typically see a significant decrease in mass and the significant decrease in left ventricular mass to volume ratio. And this was early identified by Dr. Lifschultz and Dr. Cullen, who identified decreases in left ventricular mass associated with increase in end-systolic wall stress that preceded the changes in function. Similarly, in adults with reduced ejection fraction, there is a relationship between anthracycline dose and left ventricular mass index. And left ventricular mass was strongly associated with major adverse cardiovascular events. So myocardial strain is defined as the percent change in length in a given direction, with longitudinal and circumferential shortening denoted by a negative value and radial thickening by a positive value. But beyond strain magnitude, we need to understand the concept of mechanical desynchrony in heart failure patients. And you can see on the right-hand side of this slide how not only there are changes, and this is the various segments of the myocardium, there are changes in the strain magnitude, but you see that the time to peak really varies between all these myocardial segments, and that's very clearly associated with decreases in stroke volume. And higher desynchrony indexes have been previously identified in patients with anthracycline and radiation-exposed survivors compared to control. So really important. So we looked at both things, magnitude, but also desynchrony. A reduction. So in terms of what are the numbers that we're looking for, especially in pediatrics, so we looked at a reduction in absolute strain by greater than 15% of a baseline value. An absolute GLS value more negative than minus 18% is considered normal. A value between 16 and 18 is considered to be borderline, and less than minus 16% is considered to indicate left ventricular dysfunction. And as I mentioned, reduction in global longitudinal strain precedes reductions in global circumferential strain and in ejection fraction. And just to give you some reference values for pediatrics on mean left ventricular GLS, and you can see that for global longitudinal strain, the confidence interval is relatively narrow, similar for GCS, and this is for MRI. Well, the confidence interval for a global radial strain is much larger, which is one of the reasons why we don't really use it on a clinical basis. And we get to fast strain encoding, and strain encoding was really initially demonstrated in 2001. And with further development of this sequence, now we are we have fast strain encoding MRI, which enables single heartbeat acquisition, significantly reducing the scan time. One thing that is important to remember is that for FSENC, longitudinal myocardial strain is perpendicular. So you're basically measuring strain perpendicular to the acquisition. So you obtain basal, mid, and apical short axis views to assessment of longitudinal myocardial strain, and then 2, 3, and 4 for assessment of circumferential strain magnitude. And we calculate myohealth based on the percent of normal segments that have a strain magnitude that is less than minus 17%. So in the normal myocardium, you should have at least more than 80% of segments, myocardial segments, having a segmental strain more than minus 17. Here you see another of our patients. This is a 14-year-old male, and I'll show you more detailed information on this patient later with Ewing sarcoma. And you can see that has significant reduction in myohealth. You see that only 32% of the segments are normal. You see there is abnormal global longitudinal strain, very significantly reduced both on the left and the right ventricle. So this is just quickly to show you how do we acquire these prescriptions. So as mentioned, for assessment of circumferential strain, you acquire long axis slices in the 2-chamber, 3-chamber, and 4-chamber, and this is how you acquire in the short axis for assessment of global longitudinal strain, typically a basal, mid, and apical slice. And these acquisitions are done in systole. And I can say we actually routinely use a strain not only for assessment of cardio-oncology patients, but for adult congenital patients. And it becomes pretty routine and easy to perform. So first case, also, as I mentioned, we use MyoHealth to re-stratify our patients. So if our MyoHealth is more than 70%, we consider those patients to be at lower risk. So no immediate action is needed, but we do very close monitoring of these patients. Once they go into the moderate risk, so the early heart failure stage B, we then start heart failure medication. In the pediatric population, we see significant comorbidities that contribute to myocardial deformation abnormalities, and those include diabetes, hypertension, obesity, sedentary lifestyle, and obviously the concomitant use of other medications and radiation therapy. So that's why it's so important that we do a very precise risk stratification of these patients to really understand who will require more close monitoring. And finally, obviously, we're going to be more aggressive in our higher risk patients with more advanced, maybe heart failure stage B plus, C or D. So in conclusion, CMR is the gold standard for quantifying global and regional myocardial function. MyoHealth less than 70% and GLS below 17% is able to successfully identify early stage B patients. CMR uniquely evaluates the tissue characterization of the left and right ventricular myocardium and really enhances our ability to understand where is our patient in the early or late state, and very importantly, in the evaluation of myocarditis.
Our thanks to Dr. Toro-Salazar for such an excellent presentation. I'm sure you enjoyed that, and if you'd like to learn more, please go to the ICOS website where you can access the full webinar. Of course, at the ICOS website, you can also access all things cardio-oncology, including information regarding the upcoming Global Cardio-Oncology Summit this fall, 2025, in South Africa. We hope to see you there, and until the next time, we remind you to treat cancer, protect hearts.